My friends, I want to talk to you today very simply about government.
We need to use diplomacy and build international consensus to resolve our problems whenever possible.
Our diplomats are working with a range of partners to strengthen human rights protections.
This is not a time to undercut our diplomats.
And today, in our boasted modern civilization...
Welcome to Diplomatic Immunity. My name is Alistair Somerville, editor at the Institute for the Study of Diplomacy and producer of this podcast. I'm here with our Director of Programs and Research, Dr. Kelly McFarland. With the COVID-19 pandemic affecting the United States and countries all over the world, and the ongoing challenges of pandemic response and rebuilding healthcare systems and capacities in the most vulnerable regions, we wanted to understand how diplomacy can help governments and societies respond to outbreaks of disease. So this week we spoke to Dr. Claire Standley. She is an assistant research professor at the Center for Global Health Science and Security at Georgetown University, with appointments in the Department of Microbiology and Immunology and the Department of International Health. Her research focuses on health systems strengthening and international capacity building for public health, with an emphasis on prevention and control of infectious diseases in both humans and animals, as well as public health emergency preparedness and response. As we discussed in the interview, she was previously an American Association for the Advancement of Science and Technology Policy Fellow at the State Department, and is also an editor of the Science and Diplomacy Journal. She is well placed to give us some insights into pandemic preparedness and issues of diplomacy and global health. We also discussed the diplomacy case study that Claire wrote for ISD in 2019, the 2014 to 2015 West Africa Ebola outbreak, the diplomacy of response and recovery in Guinea. The case is one of over 250 we have on international relations and diplomacy in ISD's online library, and makes some key insights on how countries around the world should and should not respond to infectious disease outbreaks. Clearly, the current pandemic has shown how some countries have absorbed those lessons better than others. The 2014-15 Ebola outbreak in Guinea, Sierra Leone, and Liberia killed more than 11,000 people and offered a stark reminder that viruses do not recognize international borders. The outbreak left the global public health community scrambling to respond quickly to help those infected with Ebola and stop the spread of the disease. We've put a link to the case study in our show notes. But Kelly, what was your main takeaway or insight from this discussion with Claire?
I was struck once again on the importance of bridging the gap between policymakers and scholars and scientists. This is something we touch on from time to time on the podcast, and it's a large part of what we do here at ISD. Claire reaffirmed how important it was for both sides to take the time to learn more about each other's work, processes, and audiences in order to create the most useful outcomes for all involved. That applies whether you're talking about pandemic response, a melting Arctic, or great power competition.
And I also just wanted to add that after we talked to Claire a couple of weeks ago, there was unfortunately a new Ebola outbreak in Guinea. So if you ever listen through to the end of the conversation, you can hear Claire give us a quick update on what has happened there and tie those developments back to some of the key aspects of successful and unsuccessful epidemic response. Let's listen to the conversation. Claire Standley, thank you so much for joining Diplomatic Immunity today.
Thank you for having me. It's a pleasure to be here.
So to get us started, tell us a little bit about your analysis of the Ebola pandemic that we saw a few years ago, and the case study that you wrote for us here at ISD on the response in Guinea. What were some of the lessons and key takeaways given the situation we find ourselves in today?
Yeah, I think one of the key things was that the importance of communication and coordination between partners. So obviously the Ebola response in West Africa, and particularly in all three of the most affected countries, so Guinea, Sierra Leone, and Liberia, ended up becoming a very large-scale humanitarian response. In fact, it was the first time that the United Nations actually set up a special mission for a public health emergency. So it's the first time that the UN General Assembly recognized the scale of the impact that an infectious disease could have in this sense, and created the special mission for Ebola response, which ended up helping to coordinate some of the activities on the ground. So I think that's one of the key lessons learned, is that, there had been talk previously about how HIV/AIDS, for example, in the early 2000s was a potential security threat. But this was the first time I think the global community recognized the wide-ranging geopolitical, diplomatic, and humanitarian impacts that an epidemic could have. And we saw that being reflected in the response as well. In terms of the specific case study, I think one of the aspects that I focus on in some parts of it is really the geopolitics of foreign assistance. And I think in Guinea in particular, it's just so fascinating to see how Guinea's post-colonial history was reflected in the way that donors engaged in the country, and how it was much more nuanced and complicated than in Liberia and Sierra Leone, where there seemed to be a much more straightforward post-colonial relationship between the countries and their previous colonial influences. So that to me was very interesting, and I think again reflected how the world hasn't changed maybe as much as we think it has over the last 70 years, but also some lessons learned for post-colonial respect and partnerships when it comes to foreign assistance, and what that means for long-term health system strengthening.
It's interesting you bring up kind of the international response, because one of the things we may end up seeing in the next few months is the international community getting more involved with COVID response in certain parts of Africa. I think I saw some reports coming out the last few days that there are some worrying signs, particularly in Southern Africa, about where the COVID pandemic might be heading. Given all of those colonial legacies and the other things you explored in your case, are there specific lessons or things that the international community might bear in mind? The UN plus other global players. What things should the international community bear in mind if there is going to be more involvement in the COVID response in Africa?
Well, I think the COVID response in general has taught a lot of industrialized nations quite a bit of humility, I would hope, when it comes to the response, and the fact that, the best preparedness metrics on paper don't necessarily stand you in good stead if your decision making or your approach to the response is underwhelming or poor. So I hope that they come to it with that sense of humility and appreciating that there are many lower and middle income countries that have done quite well in the response effort, and so that there are in fact lessons that can be learned more locally. Such that, yes, okay, maybe countries like the US and the European Union will provide funding to support response efforts elsewhere in the world. Again, presumably once they get their own houses in order. But once that happens, that there are other places where they should seek expert advice and to take that with humility. I think more generally, as I mentioned before, the broad impacts of the epidemic are also quite important. This isn't just a health response, and particularly so with COVID-19. And again, we've seen this globally. This is absolutely not restricted to Africa or other places. COVID-19 has impacts on gender equality, on livelihoods, on future economic growth, on agriculture, on climate. We're really seeing that this is a very wide-ranging pandemic, and I do hope that we find ways to leverage some of the lessons from Ebola in terms of engaging with other sectors and incorporating their inputs into response strategies. And I think that's going to be critically important, again, all over the world, not just in Africa. And then finally, I think local knowledge can't be emphasized here. One of the major shortcomings in the West Africa Ebola response was not listening to local people and not understanding how local beliefs and approaches towards disease might impact response strategies and the efficacy of the response. Again, we're seeing some of that in COVID. We're already seeing some vaccine hesitancy among populations, again, all over the world. And I do worry that taking too much of a top-down approach to assistance with a response could fall into some of those same old mistakes. And so again, really trying to work with communities, engage with them from the bottom up, and listen to local partners who understand the context and know what effective response strategies will be is going to be really crucial.
Super. I know Kelly has some questions about implications in terms of diplomacy and training, but before we move on to that, I was rereading your case study to prepare for the interview, and there was one part of it I just wanted to read back to you because it was very kind of prescient in light of what's happened since. You talk about three different types of pandemics and epidemics that can emerge. But the type we're experiencing now, which, and I'm quoting you now, highlights the importance of vigilance by all countries and demonstrates situations where international and national health authorities, including bilateral assistance, may be required to support even countries with substantial domestic resources, which I think speaks really, really well to the point you're making that, even wealthier countries that on paper were prepared quite well and whose health systems might have been well equipped, at least in theory, have struggled for a variety of other reasons in practice. So it's more of a plug for your excellent case study that we hope listeners will check out, because it's a really good example of how we can learn some of those lessons, and maybe didn't learn a lot of the lessons that should have been learned from previous outbreaks of disease.
So one thing that, just to follow up on what you just said, I run a series of working groups here at ISD that we bring together scholars and practitioners and talk about the global diplomatic challenge. And we've done stuff on the Arctic and geopolitics in the past. We just did a big one on information operations. And the one we're doing this coming semester is on food security. And as I do a lot of the background research for the working group, it's interesting to think about, you mentioned the fall-on effects from a pandemic that a lot of people don't realize when something like this starts. And one of them is food security, and the idea of, you have all these lockdowns, and then as it spreads and it becomes global, the transportation networks for food aren't the same as they are normally. The people locally can't move around as much. Markets are closed, and small landholding farmers are really affected by this. So it's kind of speaks to what you were talking about, and also talking about taking the sort of not necessarily a top-down approach all the time, but kind of getting facts on the ground, because every situation is unique and different. So I think that's important to keep in mind. But speaking of the scholar practitioner aspect of our work and what we do at ISD, you served as a Science and Technology Policy Fellow with the American Association for the Advancement of Science at the Department of State. And we've asked a lot of folks that have had dual roles before. We just talked to former Foreign Service Officer and Ambassador Steve Moll, who's now at UVA. We talked to him a couple of weeks ago on the podcast and asked him this question too. But how has your experience in sort of both worlds, in the academic world and the practitioner world, affected you in the way you look at your work, the way you do your work, and how has it helped you? Hopefully it's helped you. That's normally what we find. And another question too, because we've asked about what things we can take away from, the Ebola case and some of these other things you're looking at. But are there any sort of glaring examples of what not to do and what you can learn that you shouldn't do moving forward that stick out?
Great questions. I'll try and tackle them one at a time. So, I think it's completely fair to say that I wouldn't be here talking to you today if it hadn't been for my time at the State Department. So, before I was very much an infectious disease biologist. That was my training. I had done a little bit of, I would say, work that had policy implications, in that I was working with ministries of health. My thesis had been based on neglected tropical diseases in East Africa. So I'd worked with the ministries of health in Kenya, Tanzania, and Uganda to help design more effective strategies for schistosomiasis control and things like that. But, again, very sort of localized translation of findings. And it was only at the State Department where I really gained an appreciation for the complexity of the policy process, both in terms of all of the factors that go into that decision-making and all of the different actors that are involved, even just within the US government. Departments and agencies that have to contribute to that process, and it was pretty extraordinary to me. And I think it really, in terms of translating that back into my academic work, we talk a lot at the Center for Global Health Science and Security about sitting at the policy and practice nexus, right? So translating evidence for use by policymakers. And in fact, almost all of us working at the center, all of us faculty, more or less, have had some experience working in government. And I think that's given us that appreciation that it's not as simple as just telling a politician or a decision maker, well, the evidence says X, so that's what you have to do. It's so much more nuanced than that. And I think that's something that academics often struggle with a little bit, since the world is quite black and white often in science, or we're used to quantifying our uncertainty in very sort of measurable ways and saying, well, I'm not completely sure, but these are the reasons why I'm not sure. And unfortunately, your assistant secretary doesn't want that as an answer. They want to be told, okay, well, what should our policy move be? And so understanding those nuances and the different factors that play into decision making in the academic world, in science versus in policy, I just think has been really enlightening for me, and something that I hope to carry forward more in my research as well. And then in terms of glaring mistakes, I think I hope I'm not repeating myself, but any time where there has been partnership attempts or assistance attempts that don't come in good faith, I think tend to cause damage. And to some extent that involves, those are examples where local communities haven't been consulted, where local partners aren't being brought in to contribute to decision-making, who aren't sitting at the table. Generally situations where someone comes in from the outside thinking that they know best and trying to impose that solution on a situation, those are the situations that don't tend to end particularly well. They don't necessarily always end badly, but they don't tend to be the most effective, sustainable solutions that contribute not only to a positive health outcome, but also to improved collaboration, understanding, and diplomatic outcomes as well. So I think that to me is really at the core of what we think of as global health diplomacy, is advancing both diplomatic and health outcomes through these interactions. And so not thinking it as a zero-sum game for one or the other.
Scientists and politicians and policymakers need to learn to speak to each other better, whether that's foreign service officers, diplomats learning a little bit more science, whether or not that's scientists learning a little bit more on how to speak without as much jargon. And also, like you said, sort of coming up with, yes, here's the science and the data, but what do we do with that then? I think that's useful for policymakers. And there's been a lot of, I know one of the big sort of memos, reports that was done recently from the Council on Foreign Relations talked about this, bringing in a lot more science for, whether that's bringing in scientists to work more in the State Department, or training foreign service officers and civil service officers more, giving them the opportunity to go get training in science and whatever aspect of science that is. But I think it's a key point in this sort of bridging the gap.
Yeah, and again, I'll make a plug for it since I'm a former fellow, but the AAAS program that I was part of, that was exactly what it was designed for, right? It was designed to put scientists in policy positions within the US federal government, both to help them gain understanding of how policy takes place, but also to improve science policy in the government itself. And many of my colleagues have gone on to long and distinguished careers within the US government. I think one notable person to mention is Dr. Beth Cameron, who's now the Director of Global Health Security at the NSC. She's a former AAAS fellow. We're scattered throughout Washington and elsewhere. Many have joined the Foreign Service and serve as diplomats overseas now. So again, I think that's one very successful pipeline for bridging that gap, by bringing scientists and medical doctors and veterinarians as well, I should note. So people with that sort of biomedical training into the government. And I think that there's certainly, when I was at State, there was a lot of interest and a lot of willingness to provide those opportunities for more scientific training to the civil servants and foreign service officers who were there. And I felt like, at least at the time, it was a very open atmosphere in terms of trying to generate opportunities for sharing skills and gaining that understanding. And hopefully that kind of approach can continue.
So I'd love to know a little more about your work during this current pandemic and the kinds of things you've been focused on. With global health security now more in the spotlight than ever before, what sorts of topics are you looking into, especially in relation to this kind of nexus of global health and diplomacy, humanitarian response that clearly played a big role in the Ebola case? But tell us more about some of the topics you've been thinking about over the past year.
Yeah, I think there's a couple of different categories of things. So, perhaps one of the more practical sides has been how do we strengthen those global health security tools that we have, that we know work, and how do we make sure that those are being used effectively in the COVID-19 response? So, for example, actually starting in Guinea and since then, I've done quite a bit of work on public health emergency management as a field of practice that tries to improve coordination and response operations when it comes to emergencies. And so one of the key bits of infrastructure there are the emergency operations centers, which I think we hear talked about quite a lot in the context now of COVID-19. But we actually got some funding from the CDC Foundation to develop an online resource of self-directed training materials and other resources to help both national and subnational emergency operations center managers or their counterparts at other types of facilities strengthen the way that their facilities could respond to COVID-19. And then, more generally, and this is both myself and also many other colleagues at the Center for Global Health Science and Security, we are, of course, thinking very deeply about why some of those preparedness metrics were wrong, why some of the things have happened in terms of the countries that have been most affected by the pandemic. Does this mean that we were using the wrong indicators? Were we thinking incorrectly about how those indicators relate to pandemic preparedness? Are there ways that we can improve those types of metrics, or are metrics in this kind of sense meaningless? And we need to be taking a much more systems approach. It's all about how each piece relates to the other rather than taking these pieces in isolation. So that's something that we're very interested in both now and again, moving forward in preparation for the next pandemic, because one is pretty much inevitable, or at least an epidemic that has pandemic potential is definitely inevitable. And so it's a question of how do we improve on what we've learned this time around and make that better in the future. On the humanitarian side, just really quickly, one of the things we've been very interested in is how many of the response approaches that are doing more or less well in different places, how well do they apply to fragile and conflict environments, and particularly humanitarian settings? And again, with particular interest in countries that have been affected by conflict and so have particular needs and vulnerabilities when it comes to health system strengthening. How do you improve the response, but also leverage that to affect health system strengthening in the recovery process as well? And again, some of that stems back again to our work in Guinea, where there was this really strong interest, and I think this comes through in the case study, hopefully, where we're not just responding to an epidemic, we're really trying to build back better. And again, that's a key phrase we're hearing throughout COVID-19. But I do think it really matters. How do we leverage these opportunities and create stronger health systems at the end of them?
That's really fascinating and great to hear that you were able to get funding for the kind of online resources. But that kind of raised the question for me. There was an article in The Atlantic this past month by Ed Yong that looked at kind of areas of science that have been neglected as a result of such a focus on COVID-19 epidemics, pandemics. And obviously that was your field of study anyway. So maybe this presents, opportunities for funding new projects and challenges to tackle as a researcher. But that article also pointed out there's lots of areas of science, medicine, human medicine, animal medicine, all sorts of other diseases that have been neglected. So I'm just wondering more broadly what you see as some of the challenges and yes, also opportunities that this increased attention on your field kind of presents going forward.
Well, I think the first thing to say is that this isn't a new cycle, right? We're used to having this cycle of sort of panic and neglect come through pandemic preparedness. Of course, there's a surge in funding and interest every time there is an epidemic. You saw that after Ebola, before that with H1N1, pandemic influenza, before that with the Amerithrax attacks in 2001. So again, this is something that the community is quite used to. I think what's new this time is that it was a community, a relatively small group of people who are very interested in global health security issues. And the field has greatly expanded over the course of the past year. I think, on balance, I think that it's great that we have so many new voices and perspectives and different types of expertise that are coming into the field. I think what's going to be interesting is who's going to stick it out and remain part of this community after the initial surge of interest and pandemic funding is maybe starting to decrease. And that's going to be sort of more how the field progresses. And related to that, I think one of the things that there are luckily very, very smart people working with the Biden administration now to try and break through that cycle of panic and neglect. How do we actually sustain appropriations and sustain the interest in things like preparedness, which don't go away in between epidemics? In fact, that's exactly the time that you should be focusing on preparedness, is when you aren't trying to do a response at the same time. How do we actually break out of that cycle and have a much more focused approach to global health security? So I'm hopeful that the renewed attention to the issue now and the fact that it really has become bigger than ever before is a positive sign in that respect. And that we are going to maybe get some new and innovative thinking along the way based by all these new people who are engaged in the field.
Well, I think that's a good place to wrap things up. So thank you again, Claire, for joining us today.
Thanks so much for having me.
Thanks, Claire. That was great.
And now here's Claire giving us a quick update on the latest Ebola outbreak in Guinea.
A couple of important sort of definition points is, I've had students already ask me, why is it already being called an epidemic in Guinea when really there's only 7 cases that have been identified? And I think that is a really important point first, because it speaks to some of the preparedness that the government of Guinea has put in place since the outbreak that started in late 2013 and carried on to 2016 previously. And so part of that was redefining the thresholds that constitute an epidemic or an outbreak of various diseases. And so for certain endemic diseases like malaria, you might need to have quite a high number of cases or an unexpectedly high number of cases in a certain amount of time for it to be considered an outbreak or an epidemic. But for Ebola, that threshold was set at 1. So any case of Ebola that's confirmed and any cluster of cases is immediately categorized as of concern and requiring response effort. So that's just the first thing to note. This latest cluster of cases was reported just a few days ago on the 14th of February, but already the investigation seems to have revealed that they can be tracked back to a burial that took place on the 1st of February. So 2 key points there. One is that this is pretty quick detection. One of the big problems the last time round was that the index case was traced back to the end of December, and the cases weren't confirmed until the middle of March. And of course, now we've got just about 2 weeks between that index case being identified and now the confirmation. The confirmation also took place in a Conakry laboratory, which is great. So again, those laboratory capacities have been strengthened. And going back to the case study, that was obviously a key part of the global health diplomacy and the health system strengthening that was implemented during and after the last epidemic. But it is a bit concerning that there was that 2-week period, and certainly the investigation has also gone back to reveal that the individual who passed away and who was buried on the 1st of February had actually started seeking care as early as the 18th of January. So there were already a couple of weeks where it's believed that she sought care at a couple of different facilities in her area in Zerakari region in Guinea, in the southeastern region, which is the same region that the other outbreak started as well. And I think the piece that I want to highlight there, the slightly worrying aspect, is despite all of the surveillance structures that have been in place, despite all of the investment in disease detection and diagnosis, it appears that in the first health center she went to, she was diagnosed with typhoid. She then sought consultation at a second facility where they said she had malaria. And finally, she consulted a traditional practitioner. And then she died just a few days later, sadly. And the related cases that have been detected are her family members and this traditional practitioner that she visited. So on the one hand, we see some really positive signs in terms of the rapid detection and the notification to the Ministry of Health. On the other hand, there do still seem to be some weaknesses in terms of that initial clinical recognition of a disease of concern that may have led to additional transmission taking place. All of that said, in terms of the response effort, WHO is obviously notified very quickly. They've already committed to responding. They've committed facilitating the mobilization of vaccines, which were of course developed in large part and trialed in Guinea as a result of the last outbreak. So a real example of some of the positive scientific collaboration that's come out of the last outbreak. And so hopefully those will be available soon and can be combined with the other locally driven response efforts like the contact tracing and the mobilization of teams to go investigate any further cases, which is already ongoing. So all said, I think the Ministry of Health has been very proactive and seems to be very much on top of things. Of course, the concern is that this is happening alongside the COVID-19 pandemic. Guinea has also experienced several other major outbreaks over the last year, including yellow fever, vaccine-derived poliovirus, and measles. And so I do worry about the response fatigue that may be faced by some of the people who are on the ground. They've had to deal with an awful lot, and anyone in any setting would be overwhelmed based on the amount that they've had to do over the last year. So hopefully they can continue the great work that they've been doing, and this will be contained very quickly.
That was Diplomatic Immunity. Thanks for listening. Please rate, review, and subscribe to this podcast, and tell your friends and colleagues to come find us on Apple Podcasts, Spotify, or wherever they listen. Follow us on Twitter at GU Diplomacy, and visit our website isd.georgetown.edu.